Pudendal neuralgia, pudendal entrapment, those are very, very ugly statements. Everybody's afraid of it. Nobody wants to have it. But yet, when you Google pelvic floor pain, what's the number one diagnosis that comes up is pudendal neuralgia or pudendal entrapment. Please, please, please. 4% of pelvic floor pain patients have pudendal nerve involvement. 4%. What are the chances that you are those 4%? But let's say you are. Fine. I love pudendal nerve because nervous system is very interesting, right? Once you find it and you decompress it along the pathway, it kind of starts to behave. So you have to be very knowledgeable when it comes to your nerves. So you have to know your entire lumbar plexus, your entire sacral plexus. You have to know where your nerves are starting, at what spinal segment, where are they coursing through the body, because everywhere where they're coursing is a chance to entrap it, right? Even if it's myofascia that is doing it, any form of connective tissue. Doesn't have to be that it's trapped between the vertebrae or in a facet joint. It doesn't have to be. It could be just gently compressed. People say, I have pudendal nerve damage. I'm like, well, that's very scary when you say that. Let's go back. Let's go from the beginning to where the nerve branches out to where it actually terminates. And we go gentle. And I listen to the patient's body. And I look for the reaction like a cold sweat, right? Or goosebumps. So I also take out Gray's Anatomy and I show the patient, this is where your nerve is. This is where it starts. These are the branches, and that's where it ends. And I go line by line. I also hold the model, and I say to the patient, right? We're gonna start here. I am right here now. I am also right here, and then I'm gonna be right there, and this is what it feels here. So patient can actually tell the brain, this is where she is on my body. So when I am actually poking you, the brain is aware. So it doesn't have to be mysterious to the brain. Because remember, all of this work, especially when it comes to nerves and pain, I'm talking to your brain. I'm not even talking to you, right? It's the brain and the nervous system. So I always explain to the patient, when it comes to anything with pudendal nerve, you have to start with sacrum, because that's where it originates from. But if the sacrum is not working, right, and it's not doing its mutation, counter mutation, go higher. See what the lumbar spine is doing, because that's the bigger sister. And if the lumbar is not behaving, go up. Go up to your thoracolumbar junction and see where it's going. So even though you're thinking that I have pain with sitting, intercourse, peeing and pooping, true, totally valid, but you have to see where did it come from. So sometimes you do have to go up that spine. But let's say sacrum is moving, your S2, S3 is totally free, your multifidus muscle is great, and I'm going down to sacrotuberous ligaments, sacrospinous ligaments. They usually entrap your pudendal nerve there. Free, no pain. Now I'm diving into your Alcox canal. I'm mobilizing your ischial tuberosities, your obturator internus, all of the connective tissue. And all of a sudden you go, oh, there it is. I go, again, it's just entrapped. If you came to me and you said my left side is fully numb, I've not felt it for years, it's severe atrophy, and I can't sit on my left side, it's numb, but it's painful, then it's a different story. Then we're gonna go and have maybe a little test done, some sort of a CT scan, or maybe a nerve conduction test, to see is the nerve firing slowly or something happened. The chances of the nerve to be fully dysfunctional and have absolutely no frequency, it's because you sustained severe trauma, surgical or maybe a fall or a vehicle accident. But that's very rare. That's why there's only 4% of true pudendal nerve patients. So when it comes to pudendal nerve, don't be afraid. It's a cord. Pudendal nerve is a cord. Wherever it starts, wherever it got decompressed, and wherever it's at the end is going to be the most sensitive, because the tip of the finger, and this is your entire nerve, the tip of the finger is going to be super sensitive. So people will say, I have pain right here. I'm like, yes, because that's the end of the branch of the pudendal nerve. So if it's the case, I teach you how we can decompress every single segment, and you do it as homework. Myofascial release. You do your little stretches. Some stretches will aggravate you. Great. Now we know what not to do. And I always say to patients, I could tell you what to do, but you could come back and say to me, it didn't work. I'm like, great. Now we're going to make a list of what not to do and go around it, because the brain doesn't like it. Not necessarily the nerve. The brain is interpreting it as trauma or danger. It's no problem. We could do the same thing on the opposite side, and then in a little while go back to the involved side and try it again. And maybe this time the brain is not going to protect it so much. So when it comes to any form of nerve pain, don't be afraid. We just have to know the anatomy. We have to know where it got entrapped. We have to design exercise plan and myofascial release around it, and I promise you, you'll be successful.